Hi, Medical Nutrition Therapy 1 students. I want to thank Dr. Dana for putting together this set of PowerPoints. She and I had talked about trying to put together material that really got to the basics of what you needed to know to diagnose the type of anemia in a patient and then discern when nutrition intervention would be appropriate and what the evidence suggests that best nutrition intervention would be. So I think that these particular slides, which I get to lecture on, although she developed the presentation, really do that. And I would suggest that you might even want to print some of these and keep them in your clinical binder as you start to go out and look at patients who have anemias and have the ability to look at laboratory values and determine what is really going on. So in looking at anemias, first of all, let's just remember that basically an anemia is suggesting that there's an inability to provide adequate oxygen to the tissues of the body. So in anemia, we are really considering the red blood cell, what's the condition of the red blood cell, and in particular, what's the status, what information do we have about the hemoglobin that is found in that red blood cell? Remember, the hemoglobin is the protein that carries oxygen, and we find almost all of it within your red blood cells. So hemoglobin and hematocrit are such common lab values. They're used so often that, we even came up with the abbreviation H&H for hemoglobin and hematocrit. So again, hemoglobin is a reference to a measurement of this oxygen-carrying protein. Hematocrit suggests to us the volume or the percentage of red blood cells that are found in the bloodstream. We do look at information about the red blood cell. If we look at the red blood cell under a microscope, we're going to note, is that red blood cell large, or is it normal sized, or is it small? And so we'll talk about a macrocytic, a large cell, a normocytic, a normal sized cell, or a small cell, a microcytic cell. We also look at the amount of hemoglobin, and remember that hemoglobin does have a reddish color. So if hemoglobin is low, we're going to see a pale, or the term hypochromic is often used. Or if it has enough red pigment and red color, we're going to say that it is a normochromic cell. Okay. To classify anemias overall, we can, let's talk a little bit about macrocytic anemias where I have large blood cells. The macrocytic anemias, as I am looking at lab values, I'm going to see a mean corpuscular volume. Remember, the corpuscle is another name for the red blood cell. So what is the average volume or amount of red blood cell that is found in the bloodstream? And in megaloblastic or macrocytic anemias, we are going to see this being greater than 94. We're also going to see that the mean cellular hemoglobin volume is probably going to be normal or higher, and so it will be greater than 31. So it might help you to open your textbook to page 645 and take a look at the clinical case study that is found there. Here you've got the lab values for a 27-year-old female who in the end is going to have a pretty classic case of iron related anemia. And so I think sometimes it just helps to see the actual lab values, and you will see that mean corpuscular value or volume is right there as MCV. The mean corpuscular hemoglobin volume is actually MCHC, hemoglobin content in this case. So these are also lab tests that you will see in addition to hemoglobin and hematocrit. So when I look at the cell and the cell, so I have these particular set of lab values. And I look at the size of the cell. If I have a large immature cell, there are probably 4 essential categories of what has caused this to happen. A vitamin B12 deficiency is going to be one of the most prevalent causes. This has also been called pernicious anemia. Pernicious is a very, very old word, and it means leading to death. So it does suggest that we do need to treat megaloblastic anemias and pernicious anemias that are caused by a B12 deficiency pretty aggressively. The treatment for this is actually providing supplemental vitamin B12. And you might remember that in some cases, B12 intake is inadequate, but in most, this is, it's a very complicated vitamin for you to get absorbed, and probably something has gone wrong somewhere in the digestive system, maybe a lack of intrinsic factor, maybe simply an aging and low levels of hydrochloric acid in the stomach. We may have to administer that B12 as an injection and put it directly into the bloodstream. We're also seeing it given as nasal sprays, and that can also work very effectively. Folic acid is another potential deficiency that can cause megaloblastic anemia. It may just be that the nutrition is not adequate, or there is a malabsorption that is going on. The treatment, again, is to just treat with supplemental folic acid. There are some inherited disorders of DNA synthesis, orotic aciduria, sickle cell anemia. The treatment here is going to be with medications and transfusions. There's not directly a vitamin deficiency linked to this version of megaloblastic anemia. And then we also see megaloblastic anemias show up when there are drugs that have probably altered normal DNA synthesis. So chemotherapy drugs would be noted for this, some anticonvulsants and some oral contraceptives. The treatment for these is to consider whether we can stop the drug that is causing the megaloblastic anemia. Is there something else that we can do? And in some cases, we'll go ahead and we will give a folic acid supplement. Now, there's one other kind of anemia that will show up, and it's not a true megaloblastic anemia, it's non-megaloblastic. For whatever reason, the body is speeding up its erythropoiesis, which is, the breakdown of worn out red blood cells. So we're kind of destroying those red blood cells more quickly than we should be. And the real treatment for this is going to be to treat whatever other disease is leading to this accelerated erythropoiesis. Okay, now let's talk about an anemia where I see a small pale red blood cell, or hypochromic pale microcytic small cell. As I'm looking at the lab values, I will see a mean corpuscular volume. Again, how much space are the red blood cells taking up? And it will be less than 80, and that suggests to me that, in fact, these are smaller cells than they should be. The mean corpuscular hemoglobin volume will also correspondingly be low and will be less than 30. Okay, what is likely to cause this? Probably most prevalently iron deficiency. What might contribute to iron deficiency? It might just be issues of rapid growth, inadequate dietary intake, but we also, in the patient population that we are seeing, want to consider whether there is some kind of chronic blood loss going on. And is this the reason that we are seeing this condition? The treatment for this is going to be to give supplements of iron in its ferrous sulfate form, and then look for the underlying cause and correcting the underlying cause. There are some fairly rare other disorders that may cause alterations in globin synthesis, thalassemia, and hemoglobin E and C. The treatment for this being sometimes none, and if it is severe, we'll treat with blood transfusions. There are some disorders of porphyrin and heme synthesis that might be related to vitamin B6. Those are termed pyridoxine response anemia, and the treatment will be with pyridoxine or B6. Another potential disorder of iron metabolism may come because of a copper deficiency, and the treatment for that will be to supply copper supplements. Okay, we can also see an anemia when we actually have normal sized cells and normal amounts of hemoglobin in the red blood cells. So in this case, our mean corpuscular volume will be normal between 82 and 92, and our mean corpuscular hemoglobin volume will be greater than 30. What will cause this? Probably a recent blood loss. When this happens, we will generally treat it with a transfusion. We may see iron, but again, a consideration of the underlying cause or condition will be called for. All right. Is something happening that is actually causing an overexpansion of plasma volume? This is something we see fairly commonly. And so it turns out that edema is just diluting the blood with extra fluid. Because of this dilution with extra fluid, it appears that certain substances like hemoglobin is actually low. The treatment for this is to restore homeostasis. Overhydration, again, an edema, someone who has been consuming too much fluid will see this same kind of normochromic, normocytic anemia. We may see this kind of anemia in aplastic anemia. We'll treat that with transfusion. And pure red blood cell aplasia, the treatment is with hormones, the male hormones or androgens. The infiltrated bone marrow, this is going to be secondary to diseases like leukemia, multiple myeloma, myelofibrosis. And the treatment with this is going to be to correct the situation in the bone marrow and treat it with chemotherapy. Occasionally, we see these normochromic, normocytic anemias because of endocrine abnormalities, And then we see them secondary to chronic disease, renal disease, liver disease. And in that case, our best treatment is not to give iron, but to try to treat and control the chronic disease as best as we can. On the right-hand side of the slide, you are going to see the stages of negative and positive balance. If we look at negative balance, we see that in stage 1, the body is becoming depleted of iron. Iron absorption has been reduced and stores are becoming depleted. What's interesting is it won't actually be until stage 3 that our patient will probably experience any real notable signs or symptoms. In the second stage, we note an iron depletion, and the stores of the body are now severely depleted, but it will not be until stage 3 that we can see the abnormalities show up in blood tests. The ability to carry oxygen has not yet been impacted, but I can see the beginning of the problem if I am looking at the lab tests. And it's not actually until the 4th stage that the iron deficiency is apparent and will show up as a diagnosis of anemia also. So out of all the lab values that we can look at, probably the single most sensitive lab value to tell us about iron status is serum ferritin. Serum ferritin is the chief storage form of iron in the body, or at least that I can pull out and look at from the blood cell. And it turns out that the amount of ferritin, the amount of iron that is stored in ferritin is directly relational to the amount of iron stores within the body. So if my blood ferritin is starting to get low, it's a direct indication to me that the stores of other parts of the body are also low. So that isn't as commonly done as just hemoglobin hematocrit, but by and far it is the most sensitive measure of what someone's iron status actually is. From that point, there are 2 other lab values that we will look at. This is total iron binding capacity. This is basically just saying to me, what ability do I have to pick up and carry and transfer iron around? What I'm going to see is that TIBC, total iron binding capacity, will become extremely high in deficiency. So it's almost like there are empty little storage carts that are just waiting to grab any iron that might become available. Likewise, transferrin is another major carrier of iron within the body, and it will also become high in deficiency. But in terms of their sensitivity, ferritin is our best lab value, followed by the total iron binding capacity, and transferrin would be our 3rd best measure. Now, what are the causes of iron deficiency? Inadequate intake without supplementation, inadequate absorption due to illness and surgery. Perhaps metabolically, the body is not utilizing this iron. Perhaps the body has an increased need for iron. Has there been a considerable loss of blood? And then an increased destruction of iron that is secondary to inflammatory or other kinds of chronic diseases. So in iron deficiency anemia, the production of red blood cells results in a very small red blood cell and a very low level of hemoglobin, again, microcytic and hypochromic. This again does not show up until we've had a fairly long period of iron deprivation, and it is the last stage of the deficiency. What kind of symptoms might our patient be having? Well, muscle function may not be as optimal, and the ability to get work performance done will definitely be on the decline. The behavioral changes that are noted are fatigue, a loss of a desire to eat or an anorexia. In some cases, we will see pica or a desire to consume non-food items. This seems to be linked strongly with iron deficiency anemia, and even heavy consumption of ice and a craving for ice will fall into the category of pica. Especially in children, we may see a failure in cognitive development, abnormalities of growth. The immune system is not working as well as it did previously. Other complaints may be restless leg syndrome, epithelial tissues not appearing as healthy as they had previously. And in severe cases, this will lead then to cardiovascular and respiratory diseases. A quick summary of the biochemical evaluation for iron deficiency anemia. Serum or plasma ferritin. You've got for females less than 10, for males less than 12. Again, this is our most sensitive indicator. However, low levels will show up if we also have severe protein depletion. Serum or plasma iron, we can definitely take a look at this for females. It should be less than 40 micrograms per deciliter. For males, less than 50. This is iron that is bound to transferrin. The lab value is not quite as useful. We do see very large variations even over the course of a day. Total iron binding capacity, less than 250 micrograms per deciliter. This is low. And then transferrin as another lab value, transferrin saturation. In females, it should be 15 to 50%, males 20 to 50%. This will measure the iron supply that is available to tissues. We can also see a soluble serum transferrin receptor. Females 1.9 to 4.4, males 2.2 to 5. This measures the rate of red blood cell production in the bone marrow. It is more sensitive than ferritin, but it will be elevated with iron deficiency within normal limits in chronic disease or inflammation and low in iron overload. How do we medically manage iron deficiency anemia? Well, like so many other things, we need to look at the underlying cause. And if at all possible, let's diagnose the underlying cause. Oral supplementation is iron, usually iron sulfate, iron that is bound to another mineral and therefore is in its chemical ferrous form. It's easier on the stomach and better absorbed. It usually is best absorbed on an empty stomach, but it is known to cause GI distress. It does bind with phytates, oxalates, phosphates, and calcium. So all those high fiber, high whole grain items, dairy products, sodas, all of these things are probably going to actually interfere with your ability to absorb your iron supplement. In some cases, we can give chelated iron, which means that it is bound with amino acids. That'll be a little bit better tolerated. We give 50 to 100 milligrams 3 times a day for 3 months to an adult. Ideally, we would give this for 4 to 5 months. We take 4 to 6 milligrams per kilogram and divide that into 3 doses daily. We can give some extra vitamin C. It may help in absorption, but it also has a chance of increasing gastric irritability. In practice, I don't know as though we see that used a lot. Now, the lab values will actually improve in 2 or 3 days after supplementation, and hemoglobin will start to increase in as little as 4 days. Sometimes we simply cannot get someone's hemoglobin and hematocrit levels to rise. And in that case, we may need to look at supplementing with IV iron. As far as medical nutrition therapy, the best food sources are liver and kidney organ meats in general. Beef has more iron than other meats do. We also find iron in dried fruits, dried peas and beans, nuts, dark leafy green vegetables, and added in fortified foods. Now, we've always said there's a meat, fish protein factor that makes meats a better source of iron than other non-meat or non-heme irons. This is also kind of equated in the overall bioavailability, or how readily available is this iron to the body. But do remember that the worse the status is, the better our gut generally is at adapting and allowing for a better absorption. Oh, here's a little bit on heme and non-heme iron. Heme iron found in meat, fish, and poultry tends to be 15% absorbed, where the non-heme iron found in eggs, grain, vegetables, and fruit will vary from 3 to 8%. Remember that vitamin C will enhance that absorption, and the iron that is present in your grain products and fruits and vegetables will actually be improved or enhanced if it is consumed with meat, fish, and poultry. Okay, the things that interfere, the carbonates. So think about the carbonated beverages, oxalates, phosphates, phytates. Think these substances all tend to be found, again, in some pretty healthful foods. Think whole grains, think fruits and vegetables. Maybe try not so much to take those in when you are taking in your heme iron. Tannins found in coffee and tea interfere and inhibit absorption. And then phosphate, which is found in egg yolk, also will interfere. So although egg yolks can have a considerable amount of iron, it's not really bioavailable. And I don't know as though I would say that an egg yolk is a rich source of iron because of that inhibition that is going on. Okay, now on the flip side, the opposite, I want to comment that it's estimated that about 10% of people in the population at least have a tendency to be able to develop an overload of iron. The body has a limited ability to excrete excess iron. We mainly lose it through bleeding. So it's whatever the GI tract sloughs off, perhaps a little bit that is sloughed off from the urinary tract and skin. So why does someone have an excess iron intake? Well, it might be accidentally incorporated into the diet, but in developing countries, it may come from iron-rich soils or heavy use of cast iron in cooking. In developed countries, it's more likely to come from heavy use of iron-fortified foods or supplements. There are certain diseases or situations that tend to promote iron overload: thalassemia, sideroblastic anemia, chronic hemolytic anemias, and whatever condition might lead to needing multiple blood transfusion. Hemochromatosis is a genetic condition. There are actually 3 versions of hemochromatosis. People with this genetic background absorb about 3 times more iron than individuals who do not have that gene. The impact seems to be stronger on men because they do not have menses to help rid their body of this excess iron. The assessment for this is going to be looking at serum ferritin, serum iron, total iron binding capacity, and transferrin. The medical management is going to involve weekly blood withdrawal. There are chelating agents that can be given. This means that these are agents that will bind with iron and make it unavailable for absorption. And then we also can give EDTA, which again is going to help to kind of neutralize this iron inside the body. The medical nutrition therapy for hemochromatosis is going to be to promote a decreased intake of iron, especially look at heme iron and fortified foods, to limit alcohol and vitamin C, and certainly avoid any supplements that contain iron. Okay, let me pause and we will come back and look at some of the other non-iron conditions related to anemia.